Good morning. Ooh, excuse me. Good morning, everyone, and welcome to the 1-year anniversary of Add Water and Stir. Good morning. Good morning.
Good morning.
Well, this morning, as promised, we are going to be talking about collaborative care. That is working with physicians, specialty physicians, primary care physicians, in order to bring your patients the highest standard of care. This is a question that we get all the time from our clients. It is something that is so important to getting your patient the help that they need, the care that they need, and being effective with your oral appliances.
Absolutely, Nikki. This is a collaborative treatment that, as dentists, we shouldn't try to do on our own.
Concur.
It's not appropriate for our patients' health. It actually goes against the standard of care. And if you're really interested in helping people, you're going to make sure that you co-manage your sleep apnea patients and even your snoring patients, because they have sleep apnea too, with a qualified physician. So maybe we talk about who are the best physicians to work with.
Absolutely, that was going to be my top of the interview question. So when you are identifying a patient, working with a patient, who are the best physicians to work with?
Well, the best physicians to co-manage sleep apnea patients would be physicians who are trained in sleep. Not all physicians get any training in sleep. In fact, most have little to no training. Maybe they've gone to a CME lecture for an hour talking about sleep medicine in broad brushstrokes. They probably covered insomnia. Of course, they'll cover sleep apnea, restless limb syndrome, and some of the more common types of disorders. We do know that insomnia is the #1 sleep disorder, and in many cases, if not even most cases, insomnia is also linked with obstructive sleep apnea. So working with your physicians is very important for your patients. So the best physicians would be trained sleep physicians, okay? Physicians that do get trained in sleep are certified by the Board of Internal Medicine.
Okay.
Some are also accredited through the American Academy of Sleep Medicine. And those are the physicians that you want to seek out. Now, let's talk about, you got a patient in your practice who has not been diagnosed. Okay?
Right.
So what are you going to do? Well, it depends on a number of factors. One, your location. Are you in an area where there's a large population and lots of physicians around, and therefore plenty of sleep physicians? Or might you be in a rural area where to get to a board-certified sleep physician might be an hour's drive? So these are things to consider. Also, what is your testing capacity in your practice? Okay, many, if not most, states do not have any restrictions on dentists conducting home sleep studies as screenings. So if you have testing equipment within your practice, then you've got a patient in your office who has high risk based on your examination and the questions that you ask, then sending that patient home with a home sleep test would be perfectly appropriate. Now, what do you do when you get it back? Now,
right.
That's the question. I think you have to look at the results and have to go over the study. Certainly, if patient comes back with very mild to no sleep apnea, chief complaint snoring, otherwise in good health, and you wish to move forward with an oral appliance, that is appropriate. Most of the sleep studies, if you're using your own equipment, you can then order an interpretation which will provide a prescription so that you can move forward with treatment. Whether that's going to be covered under medical insurance is somewhat questionable, but the main thing is I'm talking about whether it's appropriate or not. So we're going to leave medical insurance out of this discussion. So yeah, go ahead and treat that patient. Again, if it's either primary snoring without sleep apnea or very mild sleep apnea, oxygen levels are good, etc. Even a follow-up test with the oral appliance is considered optional under the standard of care and under the guidelines that came out in 2015. So now let's talk about the more serious cases, okay?
Right.
Moderate, severe oxygen desaturation lead you to be concerned about the overall health of the patient. Patient may have comorbid conditions, etc. Well, I think those are patients that you really ought to consider a referral, and maybe even get that referral before you actually fabricate the appliance. Now, I'm not saying that when they come back in the office and they want an oral appliance and you say, okay, well, we'll get all of our records together, and then, but I do want you to get a consultation with Dr. So-and-so. In our case, it would probably be Dr. Popper. And then we would make that referral. I'd call Dr. Popper. I'd have a sleep study, screening, if you will, that's not interpreted. And I'd call Dr. Popper. I'm referring this patient. This is what I'm finding. His AHI is 32. It seems to be positional, but his oxygen levels are his O2 sats are dropping down into the low 80s. He's spending 10% of his night with desaturations under 90. He's got a high Epworth score. He's got some comorbid conditions. Will you take a look at him? And of course, Dr. Popper is going to want to take a look at him because Dr. Popper is a physician and he cares about people's health. So that would be the referral that I would make. Now, Dr. Popper then might repeat the sleep study. He may interpret it himself and then talk to the patient about options. I think it's important that patients have all the options. I mean, we only have one tool, okay, which is our oral appliance. But a qualified sleep physician has a lot of tools and knows about all of the tools, and including SAP, and now with bongos with this EPAP, expiratory positive airway pressure, and then oral appliances, and he'll talk to the patient about all the different options and let the patient make the decision. After all, it is the patient's choice, patient's body. Now, invariably, what will happen is that we will get the patient back for oral. We'll do in our practice is after we've delivered an appliance and we've adjusted it to optimal, then we will refer back to the sleep physician for ongoing care.
Makes sense.
Yeah, it does. And so, who's benefiting here? Ultimately, the patient's benefiting.
Right.
But also, just from a networking business point of view, if you're making referrals to a sleep physician as a dentist, that's going to get you noticed as a dentist who is truly interested in patients' health. I hear a lot from physicians, particularly sleep physicians, that they don't like dealing with dentists because the dentists, A, don't communicate their office visits, and B, they don't, the sleep physicians don't get their patients back.
Right.
If you can make referrals to the physician, that's going to pay your practice dividends, of course, because you're helping the physician, you're helping the patients, everybody is benefiting.
And in a lot of these cases, you're giving the physician back a patient.
Yes.
Because if we talk a lot about external marketing, if they're coming to your practice from a Hate Your CPAP ad, you get to call that office and say, look, we have your patient here, as you may or may not know, is not using his or her CPAP, and we want to get them back into your practice.
Yes, but that would obviously be after you've gone forward and you've successfully treated them with the oral appliance. But
of course,
that doesn't mean that ongoing co-management is not appropriate. It absolutely is. So,
of course.
And new patients who are calling your office specifically for sleep medicine, like we had a call earlier this week. This is interesting.
One moment. Sorry about that.
So getting back to this, yeah, we had a call earlier this week from a new patient. I'm not sure what the referral source was. I know it was not one of our local sleep physicians, because the patient said that they had an oral appliance that they had liked and were doing well with, but it had either gotten lost or broken or worn out. I don't know exactly what happened with the oral appliance, but that they had a sleep study that was 10 years old.
Oh,
Okay, so 10 years is kind of is an old sleep study, and really ought to be repeated before we move forward with any kind of therapy or treatment. Now, I've never seen the patient before, and we want to get a sleep study. So, just think about it a little bit. In terms of benefiting my practice, even though I have testing units, I didn't want to use my testing unit on this patient who already had a previous diagnosis. I referred the patient directly to our sleep physician, Dr. Popper, and push the red button.
yep. Oh, alrighty then.
Okay, so it looks like we're blacked out, huh? Okay.
Only on one, but we'll keep going here.
All right, so the sleep physician, we made that referral directly to the sleep physician, and that way the patient will be able to go in and see Dr. Popper. Dr. Popper has a lot of home testing units, and we'll get the patient tested, and no doubt I'll get the patient back. Probably, maybe it'll take 4 to 6 weeks, but certainly the patient will come back. When I get the patient, I'll have chart notes, I'll have a prescription, I'll have everything I need to move forward, appropriately under the standard of care, and of course I'll be able to bill medical insurance and get reimbursement for the patient. So
Right.
There you go. So collaborative care, it really is something real important that you do, and that you make these referrals directly to and find physicians that you can refer to. If you are in an area where, let's say, there are no sleep physicians, well, then you're going to have to use the primary care physician. So who are some of the other sleep physicians or physicians that might be board certified in sleep? Some of the other specialties that we can consider.
Pulmonology?
Well, pulmonology is probably one of the main ones, but ENT surgeons many
Yep.
times also have credentials in sleep medicine, and reaching out to them when you evaluate your patients, when you're doing your examination, part of the exam that we teach is to evaluate both the nasal airway and the lingual attachment, the tongue attachment, if they're tongue-tied or have ankyloglossia. Those are good reasons to make referrals to ENT surgeons, and that would be something that would be very appropriate to do. So you certainly want to seek out and create a list of ENT surgeons that might be convenient. Another specialty that who is really affected by sleep apnea, their patients are, but may not be board certified, would be cardiologists.
100%.
Yes. So if you have let's say you have a patient in your practice, you do a sleep study. They have significant obstructive sleep apnea. They have tachybrady dysrhythmia. A referral to a cardiologist certainly could be appropriate, with a cover letter that's stating that high risk for sleep apnea.